Hello, everyone. My name is Corey Miller, and I'm going to talk to you about my PDSA project, which is on perioperative emergency training. This is for the Nursing 451 class, Nursing Leadership and Professional Issues for Cal State University, San Marcos. So first, we're going to review what the PDSA cycle is. There are 4 steps. The first one being the plan, where you identify the issue. Look at the quality variance, which is the performance standards. You're looking at the root cause analysis. The scope, we're going to look at the who is involved, the stakeholders, and then begin the solution process. We move on to do, which is the solution and implementation, and showing the various things that we're going to do to address the issue. Then we move on to study, which is when we perform our data analysis, and we look then to the 4th step, which is act. And those are the next steps as we then resume the plans aspect of the cycle. So this is a revolving kind of circular cycle that just continuously goes as we look for solutions and we analyze them. It's a continuous cycle. So interestingly, I found the iceberg tool, which this is a guide for systematic thinking. I found this to be kind of interesting in relation to the perioperative emergency training. And basically, for the first portion of it, we're looking at events, what just happened. And this is looking at the iceberg is only showing 10 to 15% of what we see or feel on the surface. However, most importantly, we find that the 85 to 90% that is occurring beneath the surface is equally as important, if not more, significant, and shows why the events are occurring over time. So the reaction is the perioperative staff is unprepared to handle a patient emergency in the operating room related to a post-anesthesia complication. So we're saying this event just occurred. We then move down into that 85 to 90%, looking at the patterns and trends with our anticipation. And we're saying, okay, the staff was not properly trained or educated on specific roles during patient emergency. We look then at the underlying structures, what may have influenced the patterns above, and there are quite a few, including poor communication, lack of available education, and emergency training for staff. And I'm going to throw in cognitive aids as well, because that's the kind of, that's my focus actually for this project coming up in the further slides. And then we're going to look at the mental models, which is pretty much one of the hardest things to change in this level. But what are the assumptions, beliefs, and values that people hold about this system? And they keep the system in place. So a lot of times I've heard from fellow coworkers that emergencies rarely occur. People should already know their roles during emergencies. And I work in elective surgery. A lot of times patients, most times, they're very healthy. Obviously, we get medical clearance, but that certainly doesn't mean that an emergency cannot occur in an operative room environment. So I thought that was interesting. Going back to the issue identification for the history of crisis checklists, which we're going to focus on now, and the use of cognitive aids. In 1924, Wayne Babcock he called for the use of cognitive aids in surgery and stated the importance of well-functioning teams and cognitive aids when operating emergencies occur. Now, CPR was not introduced until 1960, and advanced life support not until 1979 by the American Heart Association, which I actually found to be quite interesting because I did not know that prior to. Although there is, of course, a history backdating back to the early 1900s where Dr. George Cryle, he reported the first successful use of external chest compressions in human resuscitation. And even going back further into history, in the early kind of 1800s, the Paris Academy of Sciences officially recommended mouth-to-mouth resuscitation for drowning victims. So there, of course, were various modalities in place. However, there wasn't an actual checklist or a protocol in place until the early 1960s. A lot of these crisis checklists were originally developed and utilized in the aviation industry in the early 1970s because aviation and surgery are very similar in that they're both high stress environments. And also, they are both places where emergencies can occur, first of all, and second of all, they can occur very quickly. So checklists were implemented in the field of anesthesiology. They started to recognize the checklist use in the later 1970s by actually following the lead of the human error in the air industry, and then looking at the health provider human error in the operating room, kind of drawing similarity between both. We did have a gap there for a while with really no other checklists developed other than the CPR and the ACLS. However, LAST checklist protocol, LAST stands for the lidocaine associated systematic toxicity, was developed in 1910 for all emergency rooms due to the frequency of use for the injectable lidocaine. We in surgery use a lot of injectable lidocaine, both for local procedures, so before we even begin surgery, and then also there are lidocaine infusions that we actually put lidocaine infused fluid into the body. So these are things to be aware of, and so they developed a checklist protocol for that. Quality variance, performance standards. We're looking at like how we are compliant versus deficient. And some statistics here. So as stated by DATS 2014 of Harvard Medical, teams using checklists were 74% less likely to miss key life-saving steps in care during emergency situations than those working with memory alone. Also stated by DATS, failure rate for performing life-saving processes of care drops from 23% to 6% during simulation when checklists were available. Both of these statements are interesting because they do show that there is definitely not only a use for the cognitive aid of a checklist, but they work. And a lot of times, I think people feel the opposite. Whenever I ask fellow colleagues, they say, oh, I'm not going to have time to read anything during an emergency. And however, I've been in emergencies, so I do know that stressful situations definitely do fog your brain a bit, and to have a checklist is pretty incredible to be able to say, oh, I forgot that step, let's look at that. So it's a good reminder tool. Dr. Gwande, he is actually pivotal in many areas he's a surgeon, and he says, for decades, we in surgery have believed that surgical crisis situations are too complex for simple checklists to be helpful. However, then he also stresses that research has shown us the opposite is true, and that by completing a routine checklist prior to surgery can substantially reduce the likelihood of a major complication. He collaborated with the World Health Organization and actually implemented one of the first pre-surgical checklists out. I use it routinely in surgery for my patients and my charting, and it basically assesses all of the pre-anesthesia checks. We assess also patient allergies. It pretty much has everything that patient safety that needs to be assessed. It's interesting. It's actually a very good checklist. So I created a fishbone diagram for my root cause analysis. And as you can see, it looks a little complicated, but we're looking at 6 different main categories. So we're looking at the people, the methods, the measurements, the machine, the environment, and the materials. And all of these have subcategories that are lending towards the cause of the effect being that the perioperative staff lacks preparation and training for an emergency. I found this to be really helpful, actually, because if you look, let's say, under people, some of the causes that can lead to the perioperative staff lacking preparation and training for an emergency are patient comorbidities, kind of as a side note, because once again, elective surgery equals healthy patients. Therefore, we then aren't as like up to our level and skill level of training because we feel it's not necessary. So then when we look under machine, we can have an O2 saturation malfunction, which I've had multiple times. Outdated equipment. We actually have really small transportation elevators. All of these are events that need to be assessed prior to and may cause actually an emergency to occur. So yeah, this was an interesting diagram for me to construct, and I feel like it really did help me to assemble the issues based around the problem and to begin to look at it and deconstruct the problem subcategory wise, and then to look at a bigger picture. So I thought it was very interesting. The stakeholders in this PDSA cycle are the patient, the surgeon, the anesthesiologist, the circulator RN, and the surgical tech. I have a very small surgical center that I work out of, and these are the only people that are in both the operating room and the perioperative areas at all times. So that's all I have. Some operating rooms, of course, have other staff members around. However, these are the key stakeholders because they are the ones in the actual operating room. So the scope of the problem is that the perioperative staff needs clarification of roles and readily accessible cognitive aids to handle a patient emergency in the operating room related to a post-anesthetic complication. Okay, so these are just some clouds of thought on the plan. Of course, we want to encourage teamwork and collaboration. We want to incorporate simulation training and education. We want to always review our posted staff role information. We want to do daily checks on crash cart and anesthesia. And we want to review emergency manuals and checklists. So for the first implementation, we're looking at, or however I was looking at, placing a poster of staff roles in 3 perioperative environments, delineating the specific staff duties during a medical or environmental emergency. So in particular, for these 4 stakeholders, we're looking at what they'll do during an emergency. A surgeon will stabilize the patient's condition to facilitate either transfer or evacuation from a surgical standpoint. He will then provide emergency medical care as needed and as directed by the anesthesiologist. Anesthesia will stabilize the patient, run the code, administer emergency medical care and medications, and assist in transfer of the patient. The RN will call 911 and report the emergency. In case of fire, will pull the alarm and get the fire extinguisher. Will assist anesthesia with emergency care of the patient, fetch the crash cart, assist in medical administration and IV access, prepare patient and visitors for evacuation and transfer, coordinate the evacuation of the ASC, which is the Ambulatory Surgical Care Center, and coordinate as necessary with local agencies. In case of a fire, of course, the fire department. Surgical tech will assist the patient with stabilizing the patient surgically, then will assist in evacuating the facility as necessary, greeting and directing of first responders and emergency personnel, and assist all team members as needed. I recently did encounter an emergency that involved these 4 individuals. I was the RN, and interestingly, we did, to a certain degree, all perform our roles, with the exception of a few that could have been more fine-tuned. So this is an incredible delineation of roles, and actually what I did was I did post these staff roles in the operating room in the recovery room, as well as in the pre-op room. So that is one solution. Implementation number 2 is that I attached laminated emergency manuals to both the anesthesia cart and the crash cart. I went through a few of these different operating room crisis checklists. There aren't many, but there's about 2 or 3 that are readily available and used. And of course, you're able to replicate your license to. This one in particular, I found to be really clear and precise, and it didn't have a lot of colors to it that were going to distract from the actual reading of the information. The ACLS, I believe, is a great checklist. However, sometimes I do feel a little overwhelmed by the colors and the way that it's organized. So I found this was rather simple, and I liked this one. So some examples. Actually, this is what I did. So I placed the emergency room crisis checklist. This is my operating room. And that's the anesthesia cart that it's attached to, laminated copies. And so you can see basic setup of how my surgery center is and my operating room environment. Now these are some examples from the actual manual. So this is what I liked about it. Of course, the simplicity of it, where you start, and it's very clear. So they also say evidence of fire, smoke, odor, flash on the patient or drapes or in the patient's airway. So these, especially with fire, we do use BOVI. We use electrical equipment during surgery. So of course there always is the chance of a fire occurring. So this is one example. And then this is another example. So this, of course, is for hemorrhage, any acute massive bleeding. Where do we start? And what do we do? So we're going to, of course, call for help in a code card, and then asking who will be the crisis manager. So right from the start, we're going to assess who is going to be the leader. We're going to open IV fluids. We're going to get that IV started. We're going to look, make sure our oxygen is at 100%, and we're going to turn down any volatile anesthetics. And then we're going to get the blood bank, of course. We are going to do a couple other things, of course. Discussing a management plan, of course, that's going to be a quick call, but then we're going to make sure the patient's obviously kept warm and get labs ASAP. I mean, that's, of course, coming into one of the later steps, but it also shows about drug doses and treatments. So I just found this to be a really good checklist to have in the operating room and in the perioperative areas. So looking at the study and the analysis stage of the PDSA cycle, really looking forward, we should appoint further responsibility to the DON, or the Director of Nursing for the operative room, or the surgical center, for a yearly scheduled simulation involving all of the common operating room emergencies located in the checklist that I just showed you previously. Simulation studies, of course, are the more guaranteed way to really put the information into your mind by not only studying it, but the act of doing, and your memory, of course, associated with doing and performing the simulation. One way that we could analyze as well is to assess the staff's response using a simple survey of yes or no answers, including, did this checklist help me to feel prepared to handle an emergency in the operating room? Was this checklist easy to use? Would you use this checklist if you were presented with this operative emergency in real life? And if you were having a surgical procedure and any of these operative emergencies occurred, would you want the immediate staff to use this checklist? So we're looking at a few things there, of course, and ease of use, and of course, is it something that you feel is helpful? So another very important part of this, and of course this would be part of a simulation process, would be that after an emergency crisis should occur, the staff needs to come together and debrief within 24 hours. And they should discuss the actual steps taken during the emergency in real life, and then identify any alternative actions that could have aided the emergency process. So this works dual-fold. It gives every staff member, every member of the team a chance to express their feelings about the experience and kind of vent a little bit, because it is very stressful. So it's good to be able to talk about it and to go over it a little bit in your mind, to understand it a little better. And then also, of course, gives ample room to learn from the possible mistakes and to move forward with a better plan in the future. So I added this in because I thought it was rather interesting. In a journal, it was actually titled Simulation-Based Trial of Surgical Crisis Checklists by Aragata et al., 2013. So these are examples of the effect of the crisis checklists, so with and without, from the same team. So if we're looking at, for instance, asystole, so you're looking at with checklist, chest compressions initiated within 17 seconds, without, you have 15 minutes before chest, or 1.5, minutes before chest compression started. So it's very interesting in an emergency situation how sometimes all the thought does really go out the door, and you kind of pause for sometimes a good solid minute before beginning something like a chest compression. The importance of chest compressions, of course, it's pivotal. So also with, we're looking at same team with the unstable bradycardia, prompt transcutaneous pacing. With the checklist was established. However, with an unstable tachycardia, not a single shock is synchronized. These are things, especially with CPR and ACLS, it's complicated. There's a lot of steps along with the process, and to have a checklist there to just even glance over, even if it's one critical aspect that you've missed, you can then begin to implement it right away. That could make all the difference really in an emergency. So for our next steps, we're looking at the crisis resource management. So when we think about crisis resource management, there are a lot of key points that we want to address. So the first one is always to call for early help. We always want to err on the side of getting more help rather than just getting by with enough. And if we do know any personnel with special skills, we want to get them on board right away so that they can help and not postpone anything really during an emergency situation. We want to designate leadership, and we definitely want to see, actually my arrow is facing the wrong way, I apologize. So second would be to designate leadership. So leadership roles need to be clear and established. And that is part of what I showed you previously. And that was that right after you call for help, you want to know, okay, you want to ask your staff members, okay, who's the leader? Who's going to be the manager of this crisis? So all team members should be aware of who the leader is, and they should be, although there is one leader, every team member should be actively engaged in the plan and always asking for clarity during the way. That leads to establishing role clarity. So early determination of who will do what, and that's where the staff roles that are posted in the emergency room and the other perioperative environments are going to be able to help kind of drill that into your mind of what you are responsible for during an emergency. You always want to distribute the workload. If somebody's doing CPR and you see that they're getting fatigued, of course, you want to just have, okay, I'm going to do the next cycle. Anticipate that and jump in as needed. And you're going to clearly delegate staffs. And you always want to delegate, of course, applicably to their staff, the staff skills and abilities. You always want to communicate effectively. That, of course, is going to be one of the most important things. When you do ACLS training or anything of that nature, you always have to repeat back what the order was. I do that routinely in surgery anyway. If somebody's asking for a suture, I say, okay, and I repeat back the suture, just so there's always clarity, especially in high-risk environments such as the operating room. You always want to Anticipate and plan. You want to use cognitive aids, definitely, and that's, of course, what my project is really based and focused on, is the use of cognitive aids to help assist in surgery, in any emergency surgical crisis. Mobilizing resources is basically just getting all the resources. That includes people with special skills that you need to bring in. Of course, that includes fire department if there's a fire, all of these different things. And allocating attention wisely, of course, is avoiding distractions, which is very challenging. But if you can be attuned to that, you can, of course, be very focused. You're going to use all the available information. You're going to know your environment and know where everything is. That is, of course, one of the biggest time management wasters, I'd say. A waste of your time is, I'm trying to grab something or trying to get something last minute. Know your environment every day. Go in and check and just look until it becomes automatic. You know where things are. You can get them in a flash. It's very important. And then, of course, then finally getting to my anticipate and plan. We're always going to look for being prepared for emergencies, whether it's medical or environmental. And of course, the utilization of checklists I find to be incredibly helpful. So in conclusion, this is just a funny little cartoon. And that is why we lived on 3, showing a lot of things. Actually, it's showing communication, it's showing teamwork, it's showing patient safety. It's very critical in the operative room environment to communicate clearly and directly with your staff. If there is something that is at any time, and you don't understand a certain plan, or the timeout wasn't clear enough and you need to repeat the timeout. I think everybody has a voice, obviously, and they should definitely use it, especially in that type of environment. And once again, the use of those cognitive aids with the checklists, and hopefully yearly simulation training on emergency crisis protocol is essential. And that would conclude my project. So thank you very much. And those are my references.